Shil, you can switch on your video. We are ready now. We are live on the YouTube.
Sure, sir. चालू था.
No. Shil,
Good morning, everyone.
Shil, I have to introduce you. So I thought you'll first put on your video of the screen sharing. I'll introduce you and then you can start.
So, shall I stop the screen sharing now, sir?
Yes, please. I need to introduce you. Yeah. So switch on your video. I can't see your video.
Yes, sir. Right.
Yes.
Okay.
So, good morning, friends. Welcome back to Saturday Club of Baroda meeting. And today we have a very interesting topic. At least I did not know about this terminology, and that is USG, ultrasound elastography, palpation imaging virtual. And speaker for this topic is none other than Dr. Silsa, who always comes up with something new, something which we have not heard much about. And I know personally him as a very updated young radiologist. To introduce him formally, he is a consultant diagnostic and interventional radiologist, Vadodara, with qualification of MD, PD, CC, radiodiagnosis. His areas of special interest are interventional imaging, advanced imaging, obstetric imaging, and he has contributed to CCRI case series also. And he has been our guest speaker earlier also in Saturday Club few times. So welcome, Dr. Shil, and thanks for agreeing to be our guest speaker. Now it's over to you. You have about 40-45 minutes of talk, and we'll have some 10 minutes of discussion. So over to you, Shil. Yeah.
Good morning, everyone. First of all, I would like to thank once again Baroda Saturday Club for giving me an opportunity today. The topic for today is ultrasound elastography. The only reason I was been here, I was been informed was first to give a topic on something difficult, or rather a complicated issue of chest. Now, what I'm going to highlight today is basically an ultrasound elastography. Basically, what is elastography? Usually, whenever we come across any specific thing, the radiologist usually monitors a specific clinical presentation and then it helps in further doing it. But today, the topic I am going to highlight is screening, the role of ultrasound in screening in such topics. Let me move ahead and say, so what is basically elastography? The role of elastography these days is like you touch a patient, you see any lump, it's hard, it's soft. Basically on that particular thing, we come to know the elasticity of the tissue. So if you see a small thing, it's soft, you probably say it's benign, it's a cyst, it's a benign lesion like a fibroadenoma in a breast. But when you see something hard, you're not saying it's something hard, you feel something, it's probably a mass. The same thing will be explored today to say whether the soft tissues, they exhibit a less strain. What we mean by strain is a force. Ultrasound probe applies force to the specific tissues depending upon how it is attenuated, whether it causes less deformation or more deformation. A specific images are obtained, and that is how we call that as a virtual imaging and how we operate the pathology under. Just to highlight, I have highlighted following topics starting from why elastography, why specific ultrasound elastography, and then the end of the topic. Start introduction. I was wondering few weeks back, a following topic was highlighted in Times of India. I was pretty amazed by the article which says, should the turns into fat in liver and it can affect the kids as young as 9. Mind well, the topic was to the point, precise, and it started me thinking that probably the writer has mentioned few things, probably as a layman also now people should know. The article highlighted few topics such as NAFLD. What does this mean? It means a non-alcoholic fatty liver disease. Usually when we see fatty liver, a layman understands, oh, well, it's all related to alcohol. But mind well, this point, non-alcoholic fatty liver disease was been put up very well. And it mentioned most important thing was that association of this was probably not related to alcohol. Further moving down, the article concerned metabolic dysfunction associated steatosis, that's fat liver disease. I was pretty impressed. Says the article has interested so many things. It's better as an ultrasound radiologist, I should start spitting on this topic so that the patients, even the clinicians, should know how to pick up these things earlier. So my topic for today says artificial imaging. Mind well, it has nothing to do with artificial intelligence. When we put on artificial intelligence, and I just started sharing what is fatty liver, it blasted me blah 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 so many things. But the very next moment when I put on the same thing, how do you diagnose a fatty liver? But then at the same time, it was also pretty much short, pretty much confused, and it says it cannot diagnose the medical conditions. That gave me a sense of relief. Here comes the role of radiologist. What we are going to speak today, discuss for few minutes, is something called as an artificial imaging, nothing to do with artificial intelligence. Now, the terminology. A normal fatty liver progresses to hepatocellular carcinoma. There are certain terminologies which have been coined. One is something called as non-alcoholic fatty liver disease and a something called as NASH. What is important is for healthy liver, irrespective of a pathogen, maybe it may be an alcohol, maybe it may be some specific infections or idiopathic, some form may progress and you may end up in having some malignancies or some form of liver inflammation. So it's very important to know these two things, something called as non-alcoholic steatotic hepatic liver disease or NASH. It's known a healthy liver, usually without any specific etiology, can sometimes progress to NAFLD or non-alcoholic fatty liver, and then something called as NASH, which is basically an inflammation we called as non-alcoholic steatohepatitis. It's similar to what the pathologists see in hepatitis C virus, hepatitis B virus, but in this, there's no specific reason. Then also you see the hepatocyte inflammation. So what we are talking today is NAFLD rather than NASH, which is basically inflammation. We are not at all interested in picking up pathologies, but a specific precursor which may progress to an inflammation. Moving ahead, what is important in this NASH and NAFLD is the role of ultrasound in picking these modalities, how it will help up. You will be shocked to know the prevalence of this disease is so much. You forget hepatitis, you forget malignancies, you forget autoimmune, you forget malignancies and venous thrombosis. It's the most prevalent liver diagnosis. Mind say it's a diagnosis, it's not a pathology. We are picking up a something precursor which may turn into further more fatal. So why NAFLD and why NASH? Here comes the pathology which says a normal liver just has a fat deposition. Probably we are not able to attribute a specific cause to it. So we label it as non-alcoholic fatty liver, which is steatosis. But in words we use NASH, it all inflammation. There's a hepatocyte ballooning and it's an inflammatory process. So we mean it as hepatitis, which is steato. Basically, it's a Greek word which labels to fat and it's a steatohepatitis. And then it all progresses to cirrhosis. So it's important you start picking up NAFLD rather than we think of NASH, advanced liver fibrosis, cirrhosis, malignancies. The topic for today is going to just highlight how to pick up this non-alcoholic fatty liver disease so that you don't worry for NASH, you don't worry for fibrosis, and you don't worry for cirrhosis. The studies say it's not at all a benign thing. Oh, પેલું fatty liver છે ને ચાલશે. ના, it's not at all benign. There's a huge amount of articles going up. Long time follow-up has been done, and it says those patients who had a fatty liver versus who did not have a fatty liver, they were all progressed, and you will see the mortality associated with liver who had a underlying liver disease just because of fatty liver, it was much higher as compared to those where there was no fatty liver. So we need to stop it from progressing towards an hepatitis, that is non-alcoholic steatohepatitis. So why identify fatty liver? Most important thing is the etiology, the pathogenesis. Do sometimes patient starts asking us, how does this fatty liver occur, sir? Is there any specific things? Usually, we are not very sure why this fatty liver occurs. Recently, a new term has been coined up, something called as metabolic dysfunction associated steatotic liver disease. What does it say? Probably some will be a sedentary lifestyle, maybe a high fatty diet or obesity. But most important is insulin resistance. This is very important because they say if this insulin resistance and you have something called as an NAFLD diagnosis, there are some medicines which have been tamed down where this can be stopped rather than being reversed. So it's very important to understand this etiology. Why does this fatty liver occurs? Yes, if it's a sedentary lifestyle, if it's a high fatty diet, it's an obesity, you can always ask the patient to turn on then. But if there's an insulin resistance also, then you need to have them medicines which this fatty liver can be stopped from progressing towards NASH. Now, most important thing, you see an heavy meal, you see, oh, probably this patient will have a fatty liver. Why don't you diagnose it? What's the role in diagnosing fatty liver in such patients? We start straight away medicines. There's no role of ultrasound. Yes, you are truly corrected. Metabolic associated dysfunction liver disease, there are specific criterias there. These criterias, without any imaging modality, without any blood test, you will definitively say and you can start. But we are not important in targeting these patients. We are important in targeting those who have a normal body mass index, who have a normal diabetes, normal lipid profile, who don't have any abnormal thyroid function tests. There is no autoimmune conditions. So the most important thing for today is it's not even targeting those who have a high BMI, who are obese, but someone who is there in a normal crowd, as shown in this picture. We are targeting this type of common man because the mean age for this fatty liver is almost of 40 years. 62% of these patients, they are not diabetic, and 48% of these patients are not at all obese. So mind well, fatty liver can coexist without other comorbidities. Now, how do you diagnose it? The most important thing going ahead is clinical history and the blood reports. Usually a biochemistry where a liver enzymes, a liver function tests are usually been helped. If these patients this, normally we see a patient who's getting an ultrasound done. We had a urinary stone, the stone was to be removed, LFT was done, and then SGPT was high. So you are totally justified in that in these investigations where we see a normal abnormal bilirubin, we see all abnormal transferase, we see abnormal GGTs, SGPTs, yes. But in isolated non-alcoholic fatty liver, you will be surprised. All the liver function tests will be totally normal. You don't see anything else. You don't see any altered ratios. You don't see abnormal tests. So normal liver function test does not rule out a normal fatty liver because this will be completely normal. So we are interested in picking up a abnormality on ultrasound which has not progressed to a disease. So non-alcoholic fatty liver disease is a something which is probably a precursor of something which is very serious and very grave. Now, as far as NASH is concerned, more importantly, we are interested in picking up this, where we usually help in diagnosing by a liver biopsy, because we have seen somewhere an inflammation. This inflammation has to be picked up on a pathology. But do all asymptomatic patients with an abnormal LFT, do you feel they are justified in getting the liver biopsy done? No. Why? Not because the patient may not be willing, but there are a lot of limitations where a liver biopsy comes in. Probably a sampling error, probably a storing system. Very rarely you see an experienced radiologist, pathologist, sorry, reporting it too precise. And there is a specific meta-weight score for fibrosis, but then also it's very tedious. Yes, you have a patient with cirrhosis. Symptomatic, only thing they have an altered BMI, they have a abnormal weight, and you just see a fatty liver, and then you see, oh, limit data biopsy done. Probably that's not justified. So most important thing to do is imaging in certain cases. Why? Because despite having biochemistry, obviously we have histopatho, we want something, we are definitively showing where we are lying. Here comes the role of imaging. We need to identify which patients we are targeting. So the entire thing today is non-invasive assessment of liver fibrosis. Why non-invasive? Yeah, yes, we are touching the patient, but we are not pricking it. We are not doing the biopsy. We are not taking any specific samples. And at the same time, we are assessment of the liver fibrosis. So why elastography? You will see any tissue has a specific stiffness. You touch a jelly, it's very soft. You touch any fruit, it will be hard. So any pathology, maybe it fibrosis, maybe a cyst, or maybe a malignancy, it will affect the elasticity of the specific tissue. So we are exploiting this specific field to understand and know the elasticity of the tissue. So how do you do this? You can do this with the help of a transient elastography, very widely common as something called as a fibroscan. Second is MRI, obviously. And third, ultrasound based techniques where we see a shear wave. Now, what is important is non-invasive. These all the modalities are non-invasive to know the elasticity of the tissue and know fibrosis. What I meant by ultrasound was something totally different from transient elastography, which is something called as fibroscan. So let us go to some basics, what's going inside of these tissues. Now, as we go to physics, you know, stress is defined as force per unit area. So we apply simple stress. This simple stress may be vertical, but if that stress is parallel, we use the term shear. So a shear stress is applied parallel to the image using an ultrasound beam. We just pass that stress, it grows. How it causes the deformation, a specific images are performed. Usually the unit is pascals. We measure in kilopascals. So the report of elastography comes as kPa, which is kilopascals. Now, talking all these things, you will be amazed what really the machine must be. It must be a bit complicated machines? No, it's a very simple ultrasound probe with only a specific hardware, software, and the radiologists who are trained to do this. Now, moving ahead, fibroscan. This is a transient elastography. It's obviously a modality which is there since use. How it works is you put a small probe. Once you put the probe inside, it machine will put a small probe. It goes inside, it touches it. You don't see any specific anatomical image as shown in the video. The waves will travel, they return depending upon the elasticity of the tissue. You see on this here, the waves are traveling. Because they are traveling parallel, we use the word shear. After this, they come back, and once the waves are reflected, it again utilizes the image. Most important thing for this is you don't have an anatomical image in this fibrosis. So a fibrostrand, it's definitively there, but it's usually used in detecting an advanced stage of fibrosis, malignancies, cirrhosis, managing cirrhosis. But why ultrasound elastography? Because you have an anatomical image and you are exactly knowing what you are doing. This is a simple ultrasound machine equipped with this hardware. So what we do, you use the region of interest cover. The patient lies down. You put a gentle probe in between the intercostal space. Try to see a proper lever. Ask the patient to breath hold, target a specific region, and then you assess the elasticity. This is as simple as doing ultrasound with the help of specific softwares, where a small region, that is the region of interest, with a guided map, something we label it as a shear map, comes down. Now, going back, what is important is how does this generate the induction wave? See, what's happening inside is you will be seeing the ultrasound probe fires a specific beam. This beam goes inside the soft tissue. It goes into a specific region of interest. Once these waves are going parallel inside, at the same time, the machine fires another wave to detect the displacement of the tissue. This is something called as a shear wave. So what we are doing, we are sending the machine the pulses inside. The displacement of the pulses we are being measured. This is as simple as it is. Going back to something very basic, you can just understand as if it's something there's a idle water, you're throwing a drop of stone inside it and you're disturbing the water. Once the water gets disturbed, this type of shear waves are being produced. How much it is disturbed is being assessed. If the water is very smooth, nothing is inside, it will grow smoothly. But if there is some oil or something, some hard material, the waves won't be disturbed. That's how the propagation is all which is measured. Most important, the diagnosis and the patient preparation. Usually they say you need to do an ultrasound together with a part of the liver elastography. So usually because you see hepatobiliary, ideally patient should be fasting. 10 minutes rest are very important so that a patient should be at rest. You should know what type of diseases are to be ruled out. And then the most important is doing the ultrasound. When we do shear wave ultrasound, it comes as two parts, something called as a point shear wave, something called as a 2D shear wave. The only difference between is in 2D shear wave, we have a small guided map where we see a specific region of interest. In this point shear wave, the probe is trapped parallel in between the ribs. Mostly we see where we have to avoid the biliary radicals. You see something black linear dots, like those are the biliary radicals because those will be in bile. You have to avoid the vessels. Most important, ask the patient to hold breath. Once the patient holds breath, you need to take a specific sample, hold it, and then you need to take the values at the same spot. Now, why you'll understand why holding breath in such a modern technology, you have to hold the breath. Yes, the reason the patient is asked to hold breath is that particular time, once you enable from the switch the shear wave, at that specific time, the tissue is not moving. You fire the impulses and you allow it to come back. This takes usually between 4 seconds to 8 seconds, and that's very important. Patient should hold the breath. Once you're doing this, the machine shows something over like this. So what is this? The is a semi-transparent color map guided image. The colors in red, blue, green, they depend whether the image is smooth, whether the disturbance is there or not. So if there is a strain is low, it's high stiffly, it will be depicted in blue. It's very high strain, that is a softer tissue, will be depicted in red. This is something like a color Doppler where we see arteries, we see veins. Yes, the user can change from an artery to venous using the color mapping. Similarly, here also we can strain between blue and red. But most important, the advantage of having the color map is exactly we should know where we have to measure, because in 2D shear wave, we take a specific region of interest and then we start measuring it. So the region of interest in the center of image, you have to ask the patient to breath hold. You see a map. If the map is properly uniform in green, uniform in blue, it's fine. There should be no disturbances in between. This is the most important image. And the best part is you can focus on a specific image, or you can even retrospectively scroll back where you get a proper image which is devoid of any vessels. That's the most important advantage of doing a 2D shear wave ultrasound elastography over fibroscan, where in fibroscan you are simply targeting blindly. So what's happening here? You can see, we can see a small sample being taken, and you can take a single measurement, or in the same you can take multiple measurements. The reason is you want to have an average value. This confidence map helps us in reviewing if there are some artifacts. If the patient has not done a breath hold, you will see it will turn red. Instead of a uniform green, uniform blue, it will turn like this. So not only 2D shear waves help us in informing whether the study has been done proper, but it also increases the confidence interval you are really measuring it. Another thing, if there are some vessels crossing in between, which may be small enough, the shear wave will confidence map will definitely pick up this and alert the ultrasound specialist saying this is not the proper site, kindly take another image. So that's the role of 2D shear wave. Now interpretation. Before we start off interpretation, before we start off normal liver, fatty liver, fibrosis, there's something termed as a compensated advanced chronic liver disease. This was used. Why? Because for the liver stiffness values, we need to identify those patients. Probably they have a disease, but they are not symptomatic. So the word compensated was used. Second was advanced chronic liver disease. Why advanced? Because those patients, they had a NASH, they had some fibrosis, they may be progressing towards cirrhosis. So with the help of these liver stiffness values, you need to identify them. Once this value trumps, it can be depicted in the following stages. Because I told earlier, velocity is to be measured. It can be measured in meters per second or kilopascals. Depending what the value is generated, we can classify as normal, that is no fatty liver, high probability it's a normal study. The value trumps as 1.7 to 2.1. Absence of any clinical signs, we need to monitor for chronic compensated advanced liver disease. If the values are more than 1.7 to 2.1 meters per second, probably it's a suggestion this patient does have an advanced liver disease. And if it is very high, more than 2.4, these are all the findings which are suggestive of a significant portal hypertension is there. Now, how do the studies? This is the image, one of the patient, where you can see a simple image. Once the image has been done properly, you'd see a 2D shear wave and you measure the stiffness median. Sorry, the value was 1.2. So we don't need to remember. Even when we do the study, we go back, we see the chart, and we report it. A second case, a healthy male, stiffness value was 1.5. It came as a mild fibrosis. This type of patient should be followed up. This is a study case which was done at our place. You will be seeing a healthy male. Any radiologist should, this appears to be relatively normal liver. You should see a relatively good pattern of vessels crossing it. The liver echo pattern appears normal. But then when we did fibroscan, you see it's somewhere beneath the liver. The most important thing before we drain this is the image should be parallel to the surface of the liver. So both the rims of the surface as well as this map should be parallel. 80 to 90% should have a uniform map. It should be uniformly blue, uniformly green, and then we measure the values. The report says the velocity is 1.3 meters per second, and these are the patients where you need to pick up. This was a patient classically despite a normal liver ultrasound. We didn't see any fat deposition, but probably this was a case of NAFLD because the velocities were more than 1.3. So this is the role of ultrasound. Obviously, you will be seeing an advanced fibrosis where the measurements will be growing very high. That's an another test which was done at our place. You see the liver echo pattern is bad. So instead of just labeling them as a mild liver, a moderate liver, or a fatty liver, you are seeing the ultrasound, you see the liver echo pattern increased, you see the periportal echogenicity still preserved, so probably some form of a moderate liver. But now mild, my radiology report says mild, some another radiologist report will say moderate. So what to believe? Instead of that, we do elastography, we see the value has been depicted as this velocity is 1.7. So it's a true image in sane criteria what's growing inside. And obviously, we have an advanced liver cirrhosis where the progression will be very bad. Obviously, you should be knowing certain things before you go for a NAFLD or a fatty liver diagnosis, because there are certain pitfalls where if a liver is inflamed, probably a case of acute fever, viral hepatitis, or a patient with a systemic conditions like CCF, the vessels will be dilated. These type of findings will definitively affect it. So the starting point should be we need to rule out another things before we do this as a screening tool. Obviously, a patient with a viral hepatitis suspected, then you thumbs down, you see a liver abnormal, don't do a fibroscan, don't do liver elastography at that particular time. You are definitely going to misjudge it. Now, limitations. Obviously, there are multiple limitations, but according to me, it's only three major limitations. First, you don't see a proper USG window. The patient probably doesn't have too much body mass index, so the penetration is not there. Second thing, there are a lot of artifacts around. And third, inability to hold breath, especially in young pediatric patients, elderly patients, or severely decompensated patients with a high BMI. It's very important. Now, I just wanted to highlight this particular slide where we say a normal liver, mild fatty, a moderate fatty, a severe fatty. Stop using these terminologies at a level of ultrasound, because with the ultrasound elastography, a reference image map, we can ideally quantify the amount of fat deposition as a specific value, and we should start using those criteria to fill up the things. That's the most important thing today. We see a fatty liver, we see mild, but then the criteria says periportal heterogeneity is there, probably it may be moderate. I say to an ultrasound, my this liver is fatty, patient will come down and says a previous report was a moderate fatty. So now with this specific technology, we can put up the traces and we can say, yes, this patient has a value of this. We ask for the specific elastography values and then we grade them. That's the most important thing. Now, most important thing, which modality, when to follow it up, and how superior or how inferior it is compared to a fibroscan. Modalities are multiple. We should be able to know which modality we have to use in a specific place. The role of shear wave ultrasound over a tissue elastography, which is fibroscan, the most important thing is ultrasound elastography has an anatomical guidance. You are knowing where you are measuring. For example, a patient with a situs inversus, you are taking the spleen, you are blindly putting up a machine and then you give a value, but ideally you are not measuring liver, you are measuring the spleen. Most important, ultrasound is not influenced by a body mass index, it's not influenced by ascites. Yes, there are definitively inter and intra observer reproducibility in fibroscan, which is not at all in this ultrasound. And most important, the staging of fibrosis. It's highly accurate. Most important thing for this is fibroscan has to be used in those patients who have a fibrosis, probably advanced fibrosis. We want to stop them from progressing to cirrhosis. There we use a fibroscan. But in a healthy patients, we want to just pick up a non-alcoholic fatty liver disease before it progresses to even something called as a NASH, which is basically a fatty hepatitis. We need to do ultrasound, which is more easy, less complicated, and done can be done in few seconds. Now, despite ultrasound, do you think any other applications may be there, or it's only related to liver? No, there are multiple applications. This may be there in breast, where we use them to differentiate between a fibroadenoma or a malignancy. We can use them in prostate to differentiate a BPH versus malignancy. Thyroid, very much light breast. Recently, thyroid comes as something called as a TREDS, where we use a thyroid imaging reporting and data system. So the guidelines say all thyroid patients should be subjected to FNA irrespective of a thyroid ultrasound finding. Here, we need to write the pathologist which specific site has to be biopsied, which specific site the FNA should be done. It's very important in thyroid. Liver imaging are already covered. Yes, a role in musculoskeletal, kidney transplant, cardiac deep vein thrombosis, intravascular strain in cardiac imaging. It's all coming down and it's all under evaluation. Most important, you have a patient, you did an ultrasound, you will say you got a fatty liver. Now, the next question is patient is asymptomatic. What next? This patient has came up with a report, patient with NAFLD, no evidence of fibrosis. This patient has to be followed up. So, what will you do next? How will you follow up? Once this has been guidelines which are accepted, this is the Lowly's fellow algorithm, which says after a clinical history, you had some liver enzymes done, patient with a right upper quadrant ultrasound, and it says what does the ultrasound say? If the ultrasound was negative, there was no evidence of any fatty liver, it came as a normal ultrasound, we should continue the evaluation as necessary as a routine thing. But if ultrasound was suggestive of a fibrosis, was no specific underlying etiology, so we label as non-alcoholic fatty liver disease or non-alcoholic steatohepatitis, and recently metabolically associated liver disease. This patient should go for a review with a clinical checkup, should followed up every 3 to 6 months, depending upon the score, how close they are near to the NASH score, and then we say. But if the ultrasound picks up a compensated chronic liver disease with the altered values which are very high, more towards fibrosis, you should alert the patient to go for a liver biopsy if the LFTs are also alerted. And at the same time, most important, you picked up NFLD. You did not say this patient has a fibrosis. Encourage a lifestyle modification, encourage weight loss accountability, and most important, if you feel there is some amount of insulin resistance, obviously there are medicines in the market which are targeting this particular thing, which will be more helpful. So finally, we do an ultrasound, we see the value, there's normal liver, we forget everything. If it is a NASH, we want to avoid it from going towards steatohepatitis. We see NFLD and we avoid cirrhosis and all. Most important thing, we start picking up for the take home messages. Most important nomenclature. What is fatty liver? What is NAFL? Is it anything new? Most important, the equipment, what the radiologist, or before you advise an ultrasound elastography, you advise a specific thing, where it will be available, what's the equipment, and the most important thing, this is just a screening tool, so it's not that the patient should have specific something. Nomenclature wise, non-alcoholic fatty liver has been replaced recently in January 2022 by metabolic dysfunction associated fatty liver. Why? Some articles say probably fatty was something related to the fat boy in the town or the fat boy in the room, and it was something very cheap. And certain criteria says probably they said insulin resistance was the most important thing, because this type of patients were more obese, they have an altered BMI, and they will be associated with a fatty liver without any inflammation. So instead of a non-alcoholic fatty liver, it has been now been justified in using metabolic dysfunction associated fatty liver disease. As same as that, we use NASH. Instead of NASH, we use the word MASH. Similarly, a metabolic dysfunction associated steatohepatitis. So what we are targeting over here is non-alcohol, but at the same time, we are trying to attribute a specific pathogenesis, why it's happening. We are able to know a specific thing. Yes, lifestyle, insulin resistance, high BMI, so metabolic dysfunction. Yes, the patient does have an high BMI. patient does have oxidative stress, there are specific etiology, but liver is normal, that does not mean he is normal. But at the same time, the liver involvement is not there. What we are trying to say, most important, it's a virtual imaging, nothing to do with artificial intelligence. What we are going to target is a normal stress and the shear stress. As clinically we touch a patient, we see the jelly bean soft, a fruit bean harder. Similarly, ultrasound, it uses a specific waves. These waves are traveling parallel to the body. Though they go parallel, we use the word shear. This displacement, whether they are going smoothly or they are reversed, a specific images are produced. So it is called as a virtual imaging, because practically we are palpating the patients. Because of this, the ultrasound waves are disturbed. This helps in characterizing the tissue stiffness. And from there, we form a specific map. That specific map may be green, may be blue, and then we color code it to help us in writing this better. And most important thing, you will be worried, what does the equipment look like? It's very simple. It's only thing a specific ultrasound probe, but yes, mind well, it should have a specific hardware, a specific software. This specific software and the hardware both are very important, because routine ultrasound we cannot target a fibro strand like this, because in fibro strand it's all an non-anatomical. In this, together with the ultrasound, there are specific softwares. And finally, but the last thing, most important thing, what we need to do is clinical applications. We want to diagnose non-alcoholic fatty liver. We want to rule out fibrosis. Sometimes we want to stage whether fibrosis is there or not, because if we say the patient is in mild fibrosis, the values are there, we want to avoid a biopsy. At the same time, same modality can be used to follow it up. We see the progression, we see the response to the treatment. And most important, we help to prognosticate. Why? Because it has been postulated that liver fibrosis, whatever it happens, early detection, patients been asymptomatic, definitely there's a role, and it is reversible. The detection of the fibrosis is the most important thing. As I highlighted earlier, there's a lot of mortality, lot of consequences been affected to these certain things. So we use the word non-alcoholic because we cannot remove a specific insult. At the same time, with the help of medicines, with the help of this, we can change the reversible factor which causes this liver damage, and then we can help in getting the liver back. That was the main criteria for presenting this topic today, liver elastography, and to highlight how liver elastography will be help or is helpful rather in those patients practically asymptomatic, but more helpful in characterizing it. So I have correct what I presented in last 30-40 minutes was the current status, how it's helpful in role in the diagnosis of certain patients, how do you imagine it, the potential pitfalls where it cannot be used, and most important, the current topics.
Thank you, Dr. Thank you, Dr. Sheel. Wonderful presentation, very meticulous, very comprehensive, and at the same time very elaborate, and you made it quite simple. And we learned a lot of new terminologies also. I mean, NAFLD and all these things where we thought that these are the new terminology. Now you have come up with some more modifications in the terminology. And I'm sure there are many questions. To start with, I have a question. Are clinicians or endocrinologists started using elastography, or they are still doing their algorithms based on FibroScan?
So basically, the only thing take home is, if the patient has been used as a screening tool, we use ultrasound elastography. But advanced clinicians, pediatric hepatologists, advanced hepatologists, they use FibroScan once the patient has a full-blown fibrosis. They manage cirrhosis. So it's not something that ultrasound elastography can replace FibroScan, or FibroScan has not to be done. But this is more to be used as a screening tool. So normally what happens, every patient they come with up, nowadays patient only will say, sir, pelu fatty liver જોઈ લેજો ને, પેલી value લખી આપજો ને. So next patient will itself say and ask, sir, last time to atlu hotu. Clinicians will also say, sir, because you're doing an ultrasound, just mention that, so follow-up it will be better. Most important is when we get a patient with a pathology, maybe it may be a renal stone or maybe some cardiac issue who is getting investigated for pyrexia, malignancies. Don't use the terminology at that time because you may be hitting something and you're not knowing the liver is involved. So that's the thing where we have to avoid it.
Right.
And routinely they are advising it. So we mentioned in the reports and patients also asked it.
Right. So we see a lot of adolescents with obesity, BMI exceeding 30 and all. They are asymptomatic.
Yes.
And when we do LFT, there may or may not be raised enzyme. If there are raised enzyme, we start the whole thing. But would you recommend that even if the enzymes are fine, you
Enzymes
should
are fine,
subject them to elastography?
Yes, sir. Enzymes are normal. You see any patient, probably you say he has a bad history, probably in parents or something, siblings or something, or looking the patient clinically, you feel his BMI is normal. He doesn't look obese, but then also you need to get it tested. So whenever you need to ask, you need to get that patients to see whether fatty liver is there. Most important, you see some specific cause, you ask the patient to remove that cause. But it's very important at least identify the fatty liver is there or not.
Right. Any other questions?
Shield, from your presentation, my feeling is that almost everyone should get a screening done once for liver elastography, because as there are, even they may be asymptomatic, there might be fatty liver. So there is no specific indication. It should be like a screening tool.
Yes, sir. And what's happening nowadays is a majority of the patients they are itself asking us. They may be taking it for something else. Commonly, what we used to encounter probably a year back was patient brought an ultrasound done. Why? Because his LFT was not going down. Probably the patient was having something else. But we get a routine USG abdomen just to say whether this liver involvement is there or not. So patients are also very conscious, as I highlighted in my first talk. The education wise, it's so easy for the patient to have an access to knowledge, but probably they are not been aware how to identify it.
So there must be wide public studies or epidemiological studies also on this.
Yes, sir. And nowadays they are saying alcoholic fatty liver, probably you can manage it because you're having the precursor, you remove that. But non-alcoholic or something, this NASH, is very bad because you don't have anything in your hands, and then also the liver is dead. Sometimes the patient has a malignancy, you do an ultrasound and you find the liver is fibrosed. We need to target those patients so that they don't eventually end up in fibrosis.
Very excellent presentation, Shiv. We learned a lot.
Thank you, sir.
Sheil, it was a nice presentation.
Morning, sir, please.
What is the cost for complete study?
Sir, we charge normally 22,500, but then that includes the normal liver ultrasound, whole abdomen ultrasound. So the whole abdomen ultrasound is 1,800. So this is 2,500.
Okay.
You are muted.
Yeah, sorry. My connection was unstable, so I got disconnected. So if there are any comments here, they are welcome.
Yeah, please, sir. Any specific things?
Satish Bhai is beside you?
Yes.
Yeah. Good. Nice to see you, Satish Bhai.
Hello, good morning.
Yeah. Good morning.
Very nice of you.
Dr. Lakhani, you want to say something?
No.
Okay.
It was a wonderful presentation by Sheil.
Thank you. Nice seeing you here in club. Okay, so if there are no comments or questions, I think we can end the session here. Thank you once again, Dr. Sheel, and we always look forward to such talks.
Thanks
from
for
you
giving me an
and future.
opportunity.
Thank you. Thank you.
Good day, sir. Thank you, everyone.
Thank you all. We meet next Saturday again. We'll have Dr. Neena Vaidya, who is working with the special kids, and we'll be having some success stories from her. So next Saturday, we'll be having Dr. Neena Vaidya. She's a pediatrician from Navsari. We had her as a guest speaker earlier also when she had talked about Down syndrome. But now we'll have her sharing her experiences of dealing with these special kids when they grow up. So transition of care and the success stories she could witness because of her efforts. So be here again next Saturday morning. Dr. Vasudev, good morning. You are muted. You are mute, Vasudev. We can't hear you. He's speaking, but he's not able to.
Yeah, sorry. I said I joined a little late, but I could hear the comments from all the experts that it was an uncommon subject and well taken by all the audience. Thank you very much. Thank you.
Thank you. Thank you. So we end the session here. Thank you all.